Running a mid-sized practice involves constant operational friction, but there is one specific task that quietly eats up clinical capacity, one phone call and inbox message at a time: prescription refill management. Research published in peer-reviewed literature shows that full-time primary care providers receive roughly 12 prescription refill requests every day, entirely outside of scheduled office visits. This chart breaks down administrative tasks. Look at the right column. Research shows managing prescriptions by phone consumes 350 hours per physician annually. At current rates, those hours represent nearly $16,000 in time costs per provider every year. Because daytime hours are consumed by these constant requests, physicians often spend 1 to 2 hours every night completing electronic health record work, a phenomenon known as pajama time. Refill management is a structural financial leak. It steals highly billable clinical capacity and is a primary driver of physician burnout. The standard response for most practices is to try and hire more in-house administrative staff to manage the load. This chart illustrates the hiring environment. In late 2024, 53% of medical group leaders identified finding candidates as their biggest staffing challenge. It's getting more difficult. 59% reported the hiring challenge worsened compared to the previous year. Even when you do find candidates, retention is a struggle. Medical assistants and front office staff have the highest turnover rates of any position in the practice. The cost of keeping these roles is also rising. MGMA data shows that administrative support compensation has increased significantly over the last decade, with some roles jumping more than 52%. Practices are inflating their overhead to secure local staff, only to face continuous retraining costs because the turnover in these roles is so high. Processing a refill seems simple on paper, but the actual execution on the clinic floor is much more complicated. This diagram shows the actual workflow. A single request requires locating records, verifying dosages, checking prior authorizations, and confirming provider availability. Now multiply that by 12 daily requests per provider, while the front desk simultaneously checks in patients and verifies insurance. This creates the phone problem. Administrative staff lose half their day fielding repetitive calls from patients checking on pending refills. When these tasks aren't completed, they pile up in the physician's electronic inbox, creating a massive queue of triage work waiting for the provider at the end of the shift. There is also a regulatory risk. Inconsistent staff coverage and chaotic documentation can lead to HIPAA compliance exposure and audit failures. Relying on a localized, manual triage model breaks down and accelerates staff burnout as soon as your practice volume begins to scale. Industry research points to specific solutions. According to the AMA, switching to annual renewals with 90-day supplies and 4 refills can immediately cut refill request volume by 50%. Second, practices see better results when they assign a dedicated specialist to refills, rather than rotating the task among whoever is available at the front desk. A growing number of practices are now using virtual medical assistants who log directly into the practice EHR to manage the daily queue. These dedicated assistants follow a standardized sequence. They receive the request, process the chart, route it for final sign-off, and notify the pharmacy. Isolating this specific workflow removes the cognitive load from your local staff and eliminates the constant phone bottleneck at the front desk. Separating the refill workflow from physical clinic operations is the structural correction needed to stabilize the patient experience and staff morale. Let's look at the financial math of building a dedicated workflow locally versus partnering with a specialized firm like Staffingly. This chart compares the models. An in-house coordinator's fully loaded cost, including salary, benefits, and overhead, is $60,800. A dedicated Staffingly virtual medical assistant costs $21,600 per year. That's a 64% reduction, saving $39,200 per position every year. For a mid-sized practice replacing 3 positions, that is over $117,000 returned to the practice bottom line. This model also eliminates management overhead. The vendor handles the daily supervision, quality assurance, and reporting. Outsourcing this function is an aggressive strategy to slash overhead and reclaim your administrative budget. You might be concerned about maintaining quality control and data security when moving tasks outside your physical office. Modern outsourced workflows use AI-assisted document intelligence to automatically read and categorize incoming refill faxes and paperwork much faster than manual sorting. Integrated error prevention systems learn from historical practice data to flag anomalies before they ever reach the provider's inbox. Patient data is protected by enterprise-grade security. Staffingly holds major industry certifications, including SOC 2 Type 2, ISO 27001, HIT-Rust, and full HIPAA compliance. By delegating this task, your practice gains access to AI and compliance infrastructure that would be too expensive to build locally. The transition is fast. Teams connect to your EHR processing in 48 to 72 hours. There are no long-term contracts, and a 30-day free trial lets you evaluate the system first. This system is designed for mid-size clinics drowning in turnover and paperwork. If you are a solo practitioner with very low refill volume, your current process may still be sufficient. It is time to stop paying physician rates for administrative sorting. Reclaim your clinical capacity and start a 30-day trial at staffingly.com/demo.